Hello and welcome to Med Tutorials. This is your place for simple and easy to follow tutorials in internal medicine. If this is your first time here, please do consider subscribing and hitting the notification bell for future updates. This is going to be part 8 in the series titled Decoding the ECG. Today we're going to deal with an important topic of acute myocardial infarction and the ECG. Coronary artery disease is the number one killer around the world, and it also leads to a lot of morbidity. In practice, ECG is one of the prerequisites in dealing with coronary artery disease. It not only helps in the diagnosis but also in the management, helps in planning out the management. And very often as medical personnel, we are called to read ECGs of patients presenting with acute chest pain. And sometimes we're in a dilemma: is it a acute myocardial infarction, or is it something more benign, a more benign condition which is leading to ECG changes? So in this tutorial, we're going to look into all these details. We're going to look into how we localize a myocardial infarction. We're going to look into the evolution of changes in the ECG morphology in an acute myocardial infarction, and we'll look at some of the close differential diagnosis. So let's get started. So in this tutorial, we'll be looking at coronary artery disease. We'll be looking broadly at its classification across its spectrum. We'll look into the phases of ST elevation MI on an ECG, and we'll look at the blood supply of the heart. And once we do that, we'll be able to further localize the site of the infarction on an ECG. And then finally we'll look into the differential diagnosis of ST elevation MI, which can be quite challenging at times in clinical practice. Now, coming to classification of coronary artery disease, we are dealing with atherosclerotic coronary artery disease, and we can classify it as chronic and acute coronary syndromes. Now, the chronic ones can further be asymptomatic, or they could present as chest pain on exertion, that's your angina pectoris. Some of them could be severe forms with heart failure. What about our acute coronary syndromes? These are the ones which present mainly in emergency with chest pain, acute onset of chest pain, and they can be broadly classified as three types: unstable angina, non-ST elevation myocardial infarction, and your STEMI, that's your ST elevation myocardial infarction. So acute coronary syndrome, you have a spectrum of unstable angina, non-ST elevation MI, and ST elevation MI. Now we need to understand that this is a spectrum, and at any time one form can sort of transform into the other form. So you could have an unstable angina which goes all the way and becomes an ST elevation MI. That's why we take all three forms of acute coronary syndrome seriously. Now, all three forms will have cardiac symptoms: acute onset of chest pain, or with autonomic symptoms, or breathlessness, acute onset, and they would have risk factors, and clinically they would all appear similar. Unstable angina is ischemia without injury, whereas non-ST elevation MI is ischemia with injury, and ST elevation MI is your severe form where you have transmural injury. So how do you differentiate it? If you look ECG wise, both unstable angina and non-STEMIs will have ST depression and T wave inversions. So you'll have significant ST depression and T wave inversions, symmetrical T wave inversions, and that would show that this is either an unstable angina or a non-STEMI. Whereas in a STEMI, you're going to have your ST elevation, which is the criteria to call it a STEMI. But how do you differentiate unstable angina from a non-STEMI? Well, that's where cardiac enzymes come into the picture. In both non-STEMI and STEMI, your cardiac enzymes are going to be elevated. and that's because there is injury in both non-ST elevation MI and in ST elevation MI. So you're going to use your cardiac enzymes to differentiate unstable angina from a non-ST elevation MI. Non-ST elevation MI is usually results in a non-Q MI. That means there might not be a residual Q wave that's formed, and most of your STEMIs are going to have a Q wave that's going to be formed. But that said and done, there are minor exceptions are there where a non-STEMI could have a Q wave formation and a STEMI could have a non-Q wave formation. That's why I said early on that this is a spectrum of acute coronary syndrome. But we usually pay emphasis on STEMI, ST elevation MI, because you're going to thrombolize or take the patient for an acute intervention if he has a ST elevation MI, because the injury is transmural. It grows across layers, and if you don't take immediate steps, you're going to land up with permanent injury. That's why we pay more emphasis on your STEMI. So if you look at the myocardium, you have two layers. You have the outer epicardium and you have the subendocardium. Now if only one layer, the subendocardial layer, is infarcted, you're going to have an infarction that is isolated to a inner layer. Whereas if both the epicardium and the subendocardium is involved, that's when you get a transmural infarction. This is what we usually see in an ST elevation MI. So in the subendocardial infarction, which you might usually see in a non-ST elevation MI, your ST vector is going to move away from the surface because you have viable myocardium on the outside. The direction of the ST vector is going to be from this away from the surface. That is why when you see an ECG, in the lead which is involved, you will get an ST depression, because the ST vector is moving away from the surface. Whereas on the other hand, when you look at a transmural infarction, both these layers are infarcted, the outer layer and the inner layer, and so the direction of the vector is going to be towards the surface. So when you see an ECG, what you get is ST elevation because of the change in direction of the vector, and we use this to differentiate a transmural severe form of vessel blockage to a non-ST elevation MI. Now we're going to look at the evolution of changes. What are going to be the changes in the morphology of an ECG over time in an ST elevation MI? So there you have your baseline ECG, which is normal, and the patient develops symptoms, acute symptoms, and over minutes to hours, if you take an ECG, you would get the classical picture of ST elevation, and that's your first change that you see. In certain cases, in the first minutes or hour, what you would see is the hyperacute tall T waves which might be visible. So if some patients who come in really early into the emergency room with sudden onset chest pain, you might see these hyperacute tall T waves. After that, from hours to days later, we see the changes evolving, dynamic changes. We see the ST elevation still there, but we see Q wave formation taking place. There might be a reduction in the R wave amplitude, and importantly, you see that there's a T wave inversion that starts to take place in the terminal part of the T wave. So in the terminal part, we see a T wave inversion that is taking place. And days to weeks later, when you come to days to weeks later, what we see is that the ST segment has started to normalize. The ST segment has started to normalize, and the T inversion is more prominent now. Now you get the entire T wave is inverted now, and of course the Q waves are still there, nice and prominent. And weeks later, weeks to a year later, what we do see in the ECG is that everything has normalized, but the Q wave still persists, and this is how we can identify if a person has had a myocardial infarction in the past. And so what is significant about all this is that we see that the ECG changes are dynamic in an ST elevation MI, and this is an important point that we would use when we try to differentiate it from other causes of ST elevation in clinical practice. Because some of the other causes, like early repolarization, you won't see dynamic changes. You would see a persisting ST elevation, and you won't see changes taking place in the T wave or Q wave formation. So these are important to understand. You can have different patterns of ST elevation in MI. You could have horizontal ST elevation, upsloping. You could have convex shaped MI ST elevation. So it's important to consider a patient in the right clinical settings to take ST elevation seriously, and to consider MI until other causes are ruled out. And we also see reciprocal ST depression in the leads that are electrically opposite to the leads in which ST elevation is present, and this is something also that helps us to sort of cement your diagnosis of myocardial infarction. If you see reciprocal changes in the leads which are in the opposite direction, it goes more in favor of your myocardial infarction. Now we come to the topic of localizing the site of infarct. So using the ECG, we can very often sort of localize which wall is involved, and based on that sort of be able to say which vessel has been blocked or infarct, which vessel has undergone a blockage. So we need to know something about the blood supply of the heart. Blood supply, there are two main arteries, your left main artery and your right coronary artery. The left main artery again branches into your left circumflex artery and your left anterior descending artery. So what areas of the heart do these vessels supply? The left circumflex artery supplies the lateral wall, and sometimes to a lesser extent it supplies the inferior and the posterior walls as well. But that's not commonly. Commonly it's just the lateral wall. The left anterior descending artery supplies the ventricular septum, the ventricular free wall, and sometimes the lateral wall. Whereas the right coronary artery usually supplies the inferior wall, the right ventricle, and the posterior wall. So as I said, the inferior wall and the posterior wall can sometimes be supplied by the left circumflex artery, but most commonly it is by the right coronary artery. So what we need to understand is there can be significant individual variations in the blood supply of the heart and the wall that is being supplied. So please do keep that in mind. Here's a picture just showing the common sites of infarction and the wall that might be involved. You have your left anterior descending branch, which is involved in anterior wall infarctions, and that is just show you a cross-sectional view as to how it appears and which part of the wall is involved in left anterior descending. And your inferior wall infarctions, as I said, is commonly due to the right coronary artery involvement, but sometimes it could also be due to the branch of the left circumflex artery, which supplies the inferior and posterior wall in certain cases. These two are usually the common ones that we deal with in practice: the anterior wall infarction and the inferior wall infarction. Especially in cases of inferior wall infarction, we have to also keep an eye out for right ventricular infarctions and posterior infarctions, because most of them are have a common supply by the right coronary artery. So we do keep an eye out for a right ventricle or posterior wall infarction when you're dealing with inferior wall infarctions. So we'll just look at what are the leads that are involved. When we see wall involvement, we will look at which ECG leads supports a diagnosis of which wall being infarcted, and from that we can probably have an idea of which vessel is being involved. And so we, again, as I'm saying, you need to understand that there are a lot of variations that can take place. Sometimes when the patient is taken into the cath lab and the angiography might show a different picture sometimes from what we were expecting. So usually V2 to V4, if you see changes like ST elevation and QA formation, it's usually suggestive of an anterior wall infarction, and we're talking about the free anterior wall, and it's usually the left anterior descending artery which is involved. If you have V1 and V2 leads showing you changes, it's more likely just a septal myocardial infarction. Again, you might not see reciprocal changes, and again, it's the left anterior descending artery. So sometimes you will have V1 to V4, all the leads involved, and this would be, this is what we call an extensive anterior wall MI or an anteroseptal MI, and again, it's because of the involvement of the left anterior descending artery. In lateral wall, we come to the conclusion if we see ST elevation in 1, AVL, V5 and V6. If you see isolated ST elevation in 1 and AVL, it's sometimes called a high lateral infarction, and this might be due to the diagonal branches of the left anterior descending artery. So these are the leads which would make us suspect a lateral wall infarction. Here we would see reciprocal changes taking place in 2, 3 and AVF. 2, 3 and AVF, that is your inferior leads, they would show reciprocal changes of ST depression. So most common involved artery would be your left circumflex artery, which supplies the lateral wall, but sometimes a diagonal branch from the left anterior descending artery could cause a high lateral infarction. Your inferior leads are 2, 3 and AVF. So if you see ST elevation in 2, 3 and AVF, it is suggestive of an inferior wall infarction. And here you can see your reciprocal changes taking place in 1 and AVL, and sometimes if it's severe cases, you might see it on the anterior leads. Blood supply, as I told earlier, right coronary artery is the main supply of usually the artery which supplies the inferior wall, but sometimes branches of the left circumflex artery can also supply the inferior wall. Now if you see ST elevation in V1, you have especially in the setting of inferior wall MI, because they're both supplied usually by the right coronary artery, we have to suspect right ventricular infarction. And to confirm right ventricular infarction, you can take an ECG with special leads on the right side, V3R to V6R. So you take special leads, you put your leads on the right side, and when you say leads on the right side, it's sort of mirroring your leads which are put on your left side. And when you take these special leads V1 and when you see ST elevation V1 and you take your special leads V3 right to V6 right, you probably see ST elevations in these leads. It would confirm your diagnosis of a right ventricular infarction. And so again, the vessel is your right coronary artery. In posterior wall infarction, how do you suspect posterior wall infarction? Now here we cannot in normal circumstances put leads posteriorly, but you see those reciprocal changes taking places in leads which are opposite to the posterior wall. So you would see tall R waves and ST depression in V1 to V1 and V2, and sometimes V3 and V4 may also be involved. So what we are seeing is a reciprocal in the reciprocal leads, that is V1, V2, sometimes V3 and V4, we see ST depression and tall R waves. So when you see a patient with inferior wall MI having tall R waves in V1, V2, maybe extending to V3 and V4 with ST depression, it should give us a suspicion of posterior wall MI. So it's mainly the right coronary artery that is involved. In a very few, in rare cases, the left circumflex artery might be involved. Now, I just want to mention that you can have patients presenting with sudden onset chest pain, symptoms of myocardial infarction. The ECG will just show you a new left bundle branch block. The previous ECG was normal, patient now got chest pain and has a new LBBB, and this has to be considered as an anterior wall MI. A new LBBB in the setting of chest pain has to be considered as an anterior wall MI. And of course the vessel is the same, the left anterior descending artery. Now take a few minutes, pause and try this ECG out and try to detect which wall is involved and what sort of phase this myocardial infarction is in. So if you see this ECG, we have clear-cut ST elevation taking place in these three leads, and they are your inferior leads 2, 3 and AVF. So you have ST elevations taking place in these three leads, and that is your inferior leads. And if you see reciprocal changes which are there in 1 and AVL, and you also notice ST depression in V2 to V3 as well. So what is we see? We could diagnose it as hyperacute MI with tall T waves involving inferior leads 2, 3 and AVF. So you see the T waves, they are still upright and tall. So this is probably someone who's presented very early with inferior wall myocardial infarction. We saw the reciprocal changes in the lateral leads 1, AVL and V6. ST depression in V2 and V3, as I mentioned earlier, in the setting of inferior wall MI should give us a suspicion that this could probably be the presence of a posterior wall infarction, and this is actually the reciprocal change of a posterior wall infarction. And the vessel involvement is the right coronary artery. Now try interpreting this ECG. So if you look at this ECG, you see ST elevation in leads V1, V2, V3, V4 and maybe to a small extent in V5. Would you also see it in lead 1 and AVL? So those are your leads with ST elevation, and you're seeing ST depression in 2, 3 and AVF. So what we can say for sure is there are ST elevations in your septal and your anterior lead. So there's an anteroseptal MI, but you also have a high lateral involvement 1 and AVL, and this is possible when you have a left anterior descending artery involvement, and probably its diagonal branch was supplying the high lateral wall, which has resulted in ST elevation in 1 and AVL. So it's probably an acute anterior wall MI, anteroseptal with high lateral, because the high lateral leads are also involved, and we see the reciprocal changes in 2, 3 and AVF. Now we're going to look into the differential diagnosis of ST elevation. So you will have patients coming in with chest pain or sometimes atypical chest pain, and they might have changes like ST elevation on the ECG, but it might not be an MI all the time. So one thing that we commonly see is the early repolarization syndrome, and you could have a vasospastic angina, it's known as a Prince-Metal angina, and ventricular aneurysms. This is usually in the setting of someone who has had a recent MI and shows persistent ST elevation, which is because of a ventricular aneurysm. Acute pericarditis, acute myocarditis, these can all present as ST elevation. Left ventricular hypertrophy, or patient who has a pre-existing left bundle branch block can have ST elevations on their ECG. And the Brugada syndrome also causes an ST elevation. Electrolyte imbalances, hyperkalemia, hypercalcemia, hypothermia with the J waves or the Osborne waves can all confuse you with the ST elevation. A common cause that we see of ST elevation is early repolarization syndrome, and it's a normal variation that we do not need to treat. The problem is it's a challenging differential to anterior ST elevation MI, and usually we have some points which might be in favor of early repolarization. So it usually takes, you see it in a young age group, and a person would be asymptomatic, be having a routine ECG done, and you notice this ST elevation because of early repolarization. So if someone comes to you with chest pain and he has an earlier ECG when he was asymptomatic and it shows the same ST elevation, it's probably the same ECG change of early repolarization. And the other thing of this ECG is it will be a concave upward ST segment, concave upward ST segment elevation. So that again goes in favor of early repolarization. But as I told you earlier, if you have a patient who is high risk category for coronary artery disease and comes with symptoms of chest pain and suggestive clinical features suggestive of an acute coronary syndrome, and if you see an ECG picture like this, please do take it seriously, and you need to rule out an acute coronary syndrome. And these points just to help us. Another important thing of the early repolarization syndrome is you won't see evolutionary changes. That means if you repeat an ECG hours later, you would see that the ECG is still the same. Whereas if you were dealing with myocardial infarction, you would see an evolution of changes. You would see the T wave starting to invert, you would see Q wave formation taking place. And with early repolarization, you do not expect any reciprocal changes. So we do not expect to see any reciprocal changes. For example, you won't see ST depression in your inferior leads in such cases. What is the differential of ST depression? Your differential diagnosis. Say you're suspecting an unstable angina or a non-ST elevation MI, where you get ST depression. What could be the differential diagnosis? So you need to first of all rule out reciprocal changes of an ST elevation MI. What this means is that sometimes if you miss out ST elevation, say the patient has an inferior wall ST elevation MI, and you have sort of overlooked that ST elevation in 2-3 and AVF. What your eyes would have just picked up was ST depression in probably 1 and AVL. So it's important that you look at all the leads. You see a lead with some leads with ST depression, make sure you're not missing out ST elevation in some of the leads. So because what you might be seeing as ST depression might be the leads with reciprocal changes. And as I said earlier, in posterior wall infarctions, you could get just ST depression in V1 and V2. Left ventricular hypertrophy with strain pattern, that was a previous term that we used to use, strain pattern, where we get tall QRS complexes, and then you get an ST depression and T wave inversion due to strain, and we call that a strain pattern. Digitalis effect, again, it's one thing to look out and to ask patients, are they taking digitalis, and which could result in ST depression and T wave changes. Hypokalemia, again, could cause ST T changes. What is the differential of T inversions? T inversions can be normally seen in certain leads like AVR, V1 and V2. There's a persistent juvenile T wave inversion pattern which might be seen in V1 to V3. Right ventricular overload, pulmonary embolism, either acute or chronic, can present with T wave inversions on the right chest leads, and whereas left ventricular hypertrophy, you can get T wave inversions and your strain pattern on the left chest leads. Pericarditis, myocarditis can cause diffuse inverted T waves. Another important thing that we need to consider is cerebrovascular accidents. Subarachnoid hemorrhages especially can cause wide T inversions with increased QT intervals. So you have someone who's presented as a subarachnoid hemorrhage, and you take an ECG and you notice these wide T wave inversions. There have been times when people who are unaware would treat these patients as acute coronary syndrome. So you need to be aware that even in cerebrovascular accidents you can get wide T inversions, and that might be because of disruption in your autonomic nervous system. Your bundle branch blocks, right bundle branch blocks and your left bundle branch blocks can also cause T inversions. What about your Q waves? What is the differential for Q waves? So we have normal Q waves which are normally seen in an ECG. Your septal Q waves can be seen in lead 1, V5 and V6, and you can get your small q big R pattern or your QS pattern or QR pattern normally in leads AVL, 3 and AVF. So you need to be aware of that. Myocarditis can cause myocardial injury and Q wave formation. Hyperkalemia causes Q wave formation. Ventricular hypertrophy and left bundle branch blocks also are causes of Q wave formation. So to summarize, coronary artery disease can be acute or chronic, and your acute coronary syndromes are unstable angina, non-ST elevation MI and your ST elevation MI, and they are a spectrum of disease, and we are most concerned with ST elevation MI because we need to decide whether this person needs an intervention which needs to take place immediately. So unstable angina and non-ST elevation MI usually cause ST depression and T inversion, but how do you differentiate the two? You'll get elevated cardiac enzymes in your non-ST elevation MI. ST elevation MI, you will get evolution of changes which are seen in the ECG. First you get ST elevation, and sometimes hyperacute you get tall T waves, and then slowly the latter part of the T wave starts to invert, Q wave formation takes place, the ST depression comes back to normal, and so you see an evolution of changes which takes place in an ECG of a STEMI patient. Changes occur in specific leads depending on the vessel involved and the wall affected. So by localizing which wall is involved, which leads are involved for which wall, you'll be able to sort of find out which vessel is actually blocked. And we also saw the differentials of what are the conditions where you can get different ECG changes which might mimic an MI on the ECG. I hope you have a better understanding of the ECG and coronary artery disease, especially with ST elevation MI. And if you have any queries, you could ask me in the comment section below, and I would try to address them. And even if there's any other topic related to ECG or internal medicine which you would like me to address, please do mention that in the comments below. So till the next time, bye bye.